Now that we have regimens that have increased the complete response rate in our patients, the complete response that we measure by conventional means, immunofixation, bone marrow, do you believe that there is a need to change the definition of response to try to establish criteria to evaluate a more stringent complete response? Professor Sonneveld?
Yeah, I'm convinced that is really needed. And I make the analogy with chronic myeloid leukemia. Let's say 10, 15 years ago, that disease had a chronic phase and a blast phase. But during chronic phase, there were still detectable tumor cells. Now, if we go back to myeloma, we, like in CML, have active drugs that really improve the depth of the response. And as in CML, we are now seeing situations without detectable tumor cells, but they are still there. So I think we should introduce new levels of complete response that are able to detect lower levels of residual tumor cells. And this might also indicate how effective the novel drugs and combinations are. So I'm in favor of introducing that.
Since you have worked in the lab, how difficult is it to establish molecular response in myeloma? We know this, as you mentioned, this is something which is pretty standardized for CML, but as far as myeloma is concerned?
Yeah, you raise a point that's really important, I think. I would recognize two different technical approaches. One is by using immunophenotyping, where we can, I think, approximately go down a factor 100 from the immunofixation, a factor 100 down to immunophenotyping in detecting residual myeloma cells in the bone marrow. And we can go even further down to more sensitive, using more sensitive techniques like PCR, but this is not easy and it is laborious. So at present time cannot be used in clinical practice.
But I would like to add that people are working now on a multiplex PCR technique. So because at the time being you have to establish your own primers in order to PCR your CDR3 region. But there may be consensus primers, and that may facilitate the entire process. So it's in its early stage, but it's not impossible that in the near future we'll have an easier technique.
But for now, immunophenotype is more mature for use.
More mature, I think it's available in most centers, but it seems to be less sensitive than PCR techniques. And so I think people will work on establishing these techniques. But the question is, and that is probably has been raised by your elegant presentation, should we not only look at the clone, but should we also have the skeleton in mind? So maybe you would like to answer this question.
Yeah, I think that's an issue which becomes more and more important, because the more thorough you look in a responding patient with MRIs or PET CTs or other sensitive means of detecting myeloma, you can find foci of myeloma in the bone while the patient fulfills all standard criteria for complete response. So I think probably assessment of bone response should be evaluated, first of all, prospectively in the context of the new trials. And I know that in some of the planned or recently started trials, there are some ideas or some provisions to assess, to evaluate this question.
May I ask you, in how many of your patients with CR do you see bone healing?
We have not, by using MRI, I think that you will see pretty frequently either a decrease of the focal lesions, or you can see that the focal lesions are there, but if you administer IV contrast, they won't enhance. We have not used PET-CT in patients with CR. Now, since we're talking about the bone disease in myeloma, what you believe is the role of bortezomib in bone disease in myeloma, Professor Ludwig?
I mean, bortezomib seems to be the only drug which has an impact on osteoblast activity, and so we see alkaline phosphatase coming up in patients who are treated with bortezomib, not only those who respond, because you can achieve that with melphalan only. If the patient responds, it's natural that the osteoblast activity increases again, but with bortezomib you see it more frequently. So people ask the question whether that has a significant impact on bone health, and I think the data which are available are not clear enough. I think we should wait. They are not, for me, they are not convincing, but in vitro it's clear that this is probably the most bone-sparing drug in myeloma we have at the time being, because the IMiDs have different effects. Yeah.
Professor Sonneveld, would you like to
I
comment?
think, I agree with Professor Ludwig, but also I think if we believe in the idea of bone remodeling by bortezomib, induced by bortezomib, probably we need prolonged treatment with bortezomib in order to get a sustained effect of, on bone. And very few clinical trials have employed prolonged use of bortezomib, maybe with the exception of the Arkansas trials, Total Therapy 3. So I'm looking forward to more data on this point, but they'll be really useful and helpful for our patients if such an effect exists and if it translates into clinical improvement.
But may I ask you, as an expert on bone markers, what is the time ripe for using bone markers in order for this deciding about the continuation of bisphosphonate therapy, or should bisphosphonates just given as recommended by the?
Yeah, I think there are some studies that are addressing that this question to see whether if you have suppressed adequately markers such as NTX or CTX, then you can stop zoledronic acid and restart probably at the time that you see a rise of these markers.
The other question is, shall we continue bisphosphonate therapy in a patient who does not react in terms of reduction of bone degradation markers? So what is the recommendation at the time being?
Yeah, I don't think that there is a firm recommendation, but for sure this is a poor sign.
But the recent study from the MRC, of course, has put emphasis on the use of bisphosphonates.
Absolutely, yeah. But for a particular patient,
patients,
absolutely. But for a particular patient, we don't have a clear predictive factor to continue or not.